Your eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not multifocal.
Exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Welcome back to part 2 of my interview with Dr. Francis Falck. In this segment, Dr. Falck shares his expert insights into the most effective treatments for glaucoma and what advancements we can look forward to in managing this disease. If you're new here and enjoy our interviews, press like, subscribe, share, and hit the bell. Also, we welcome your comments. Don't forget to check out our full-length documentary, Open Your Eyes, available on Amazon Prime, Apple TV, iTunes, Google Play, and YouTube Movies and Shows. Now, talk to me about migraines and glaucoma.
Sure. Migraines are interesting. Yeah, migraines are it's vasospastic disease is what it is. People with migraines we talked about that our vessels have a muscular coat. People with migraines, when people have that scotoma, they present with that wavy vision in their periphery. That's what we call a scotoma. And what is happening in that phase is that the cerebral or the retinal vessels are going into spasm. The lumen size has decreased because the muscular coat has gone into spasm, and that's causing decreased blood flow. When you decrease blood flow going to the eye, the photoreceptor cells become dysfunctional and they stop misfiring. And people oftentimes, they'll talk about that, what we call a fortification scotoma. It'll have a jagged edge to it, and they'll see little sparklies. And those little sparklies are the photoreceptor cells misfiring because they're not getting enough blood flow. So people with migraines have what we call vasospastic disease. There's also another form of vasospastic disease called Raynaud's disease, where individuals, when they're exposed, excuse me, to a lower temperature, their blood vessels will go into spasm, and they'll get cold hands, cold feet. And those are risk factors for normal tension glaucoma. So there's a test that we can now do, the transcranial Doppler test. One thing that's done within that's a test where we look at the cerebral vessels. During that test, there's a vasodilatory component of that test. And what happens, this goes back to the autoregulatory function we talked about before, the ability of our blood vessels to change their size. During that test, the transcranial Doppler test, the vasospastic component, the ultrasound tech will ask the patient to hold their breath for 30 seconds or more. When they hold their breath for 30 seconds, the O2 saturation, the amount of oxygen dissolved in the blood, goes down. The vessels sense that. We have O2 receptors on our blood vessel walls that sense what our O2 saturation is. They sense what the concentration of oxygen is in the blood. The normal response is, again, the vessel produces VEGF, nitric oxide, etc., and the vessel should dilate. So during that transcranial Doppler test, during that vasodilatory test, what we look for is to see, did the vessels dilate? It's called a vasodilatory test. And interestingly enough, in people with migraines and Raynaud's disease, it's dysfunctional. The vessels don't dilate. They actually constrict. So they have this abnormal vasodilatory or vasoexpansion response. Now, because they're depriving their eye of blood flow, right, that person, if they have glaucoma on top of that, is at greater risk of progression. and needs to be more aggressively monitored. But we do have medication. If somebody has significant vasospasm, we have drugs, for example, they're called calcium channel blockers. So when our vessels constrict, you're going to have to comment on this because I'm trying to digest this down as low as I can, Carrie. So when our blood vessels constrict, what causes the muscle to contract is calcium influx into the muscle. Calcium influxes into the muscle constricts, it goes into spasm. We have drugs called calcium channel blockers that will block the influx of calcium into the muscle and prevent it from narrowing. So we have the ability to treat these conditions in people with Raynaud's disease and people with extreme migraine problems. And so the headache in migraine, going backwards, so people with migraines have vasospasm, but when they get the headache, it's because the vessel overdilates. In our head, in our brain, interestingly enough, the only thing in our brain that have pain endings on it are our blood vessels, nothing else.
You know, it's interesting with migraines, with the visual part of people that get the visual aura. It always lasts for about, and you could get the visual aura and not get the headache. And it always lasts about 20 minutes because I guess it's because of the size of the brain, because everybody's brain is about the same size.
Right. Yeah. And what happens during that phase is, again, so those people, the body senses that the O2 saturation is down, and that those vessels, they'll have a tendency to overdilate. So now the blood flow is being restored.
And you mentioned before about what causes the visual aura, about the photoreceptors. Can you just repeat that? That's a very fascinating situation and something that we see a lot in general practice. Somebody coming in and they have these crazy visual, you know, it could be as bad as a visual hallucination. It could be, you know, wavy vision, like you said. You can again explain what's causing those visual changes.
So the photoreceptor cells are really part of the neurological system of our eye because they're connected to the optic nerve with these tiny cables called axons. And those photoreceptor cells are very metabolically active. Just think right now when you're looking at something, those photoreceptor cells are very metabolically active. They're processing that information. They're converting what we see into an electrical signal, and they're very metabolically active. So they require a lot of oxygen. Oxygen is what drives the metabolic pathway. Oxygen is necessary for proper metabolism, proper functioning of our cells. When the blood flow in those migraine patients, when the vasospasm occurs, and we'll talk about a retinal migraine, the photoreceptor cells that are out in the most distant part of the retina, way out on the edge, they are the ones that start misfiring because they are the ones that are farthest away from the major blood vessels. The photoreceptor cells out in the peripheral part of the retina, out in the farthest part, they generally get a lot of their oxygen, what we call in a watershed phenomenon. The blood vessels don't go all the way out to the edge of our retina, so the oxygen diffuses through the retina out to those photoreceptor cells. So when the blood vessels go into spasm, they are the first ones to misfire. And they start misfiring. Your vision becomes blurry, but they also generate those little sparklies because they're misfiring, something we call photopsia. It's a very interesting phenomenon, but very frightening for anybody who experiences that, right?
And let's talk about steroids, whether it's oral steroids, like someone needs to be on prednisone for long periods of time, they're taking prednisone drops, or even the nasal sprays like Symbicort or Flovent or Advair, how that can affect the intraocular pressure inside the eye and be related to glaucoma.
Right. So there is something we call steroid-induced glaucoma, and it appears to affect about 1% of the general population when these individuals take steroids, and it can be for a shorter period of time, as a week or so, their eye pressure will increase. And again, the reason is because, as we talked about before, just think about the drain of the eye as a screen. So it's like a porous screen. We call it trabeculectum. There are little beams, little wires called trabeculum. And steroids in steroid patients that are steroid responders, people who when take steroids, their eye pressure goes up, those trabecular beams increase in size. They get bigger. And as they get bigger, the pore of the drain decreases in size. And so it's very important if you're taking steroids, steroids are very beneficial, that you're seeing your eye doctor on a regular basis and monitoring to see if you're having a steroid response. And again, what the steroids are doing is causing the trabecular beam, those little narrow beams that exist in the trabecular meshwork, to become thicker, and that decreases the pore size.
And how long does somebody have to be on steroids before the eye pressure could be affected where it could be elevated?
In general, some patients I've seen, it depends on the steroid, as we know, that some we talk about steroids that have potency. Some steroids are more potent than other steroids. In general, injectable steroids are much more potent than an inhaled steroid and nasal spray, but that's still a risk factor if a person's a steroid responder. So it depends on the steroid. But I've seen with the more potent steroids, eye pressure rises within 7 days.
And also, if someone's on steroids for a while, it could cause cataracts as a side effect.
Cataracts as well. Yeah, steroids do two things to our eyes, can raise the eye pressure by affecting the trabecular meshwork again in a negative way, or they can cause cataracts. But it's important, if you have to use steroids, steroids are beneficial for a lot of patients. Again, if you're developing a steroid-induced pressure rise due to trabecular dysfunction, that's something that can be treated by your eye care provider. So it's important, if you're going to be on steroids, to let your eye care provider know, and so they can monitor for potential side effects of the steroids. So we're not saying, I always like to belabor this point, we're not saying don't use the drug. If you have to use it, I'm sure your healthcare provider prescribed it for a valid reason, use it, but let your eye care provider monitor you for any potential side effect.
Excellent advice. Thank you for that. Now let's move over to medical management. Let's start with the category of the prostaglandins. And there's latanoprost, Travatan, Lumigan, Vyzulta. Tell us about those, and do you find a benefit to Vyzulta because of the added nitric oxide donator?
Right. So again, the exciting thing was, if we go back, obviously you can see I have gray hair, so I've been doing this for a while. In the very beginning, so we always knew that the issue with glaucoma was a problem in the trabecular meshwork. There was an issue with the drain. But the initial drugs we had in the very beginning, we only had one medication that could affect outflow, make the drain work better, and that was called pilocarpine. And pilocarpine was a miserable medication to use because it constricted the pupil, made the eyes red, burned on installation, blurred the vision, et cetera, et cetera. So most of the drugs we had initially would treat the faucet. They would cause the faucet, the ciliary body, to make less aqueous humor. So when it was discovered about 20 years ago that within the trabecular meshwork, there were naturally occurring prostaglandins, an individual working said, well, if they're naturally occurring prostaglandins, they must have a beneficial effect there. So what if we develop them into a medication, a drop we could put in the eye and instill them in the eye and see if we could make the trabecular meshwork work better? Lo and behold, that first medication was called Zoloton, which is, we also call it latanoprost. That's a generic name of it. That totally transformed the treatment of glaucoma, because now we had a medication which was put in the eye once a day, which acted directly on the trabecular meshwork to widen the pores of the trabecular meshwork and make the trabecular meshwork work better. Wonderful medication. Since then, there's been a transformation, a whole new series of prostaglandin medications that have been developed that work just like latanoprost. But in general, what you will find is that in studies that we have done, that Falck Medical has done, I've done, you will find that the prostaglandin drops are very potent. They will improve trabecular meshwork function about 35%. So, and consequently lower IOP about 35%. Because of the interest in blood flow and its relationship to glaucoma, because again, the damage that's done really from glaucoma is when the eye pressure goes up, the blood flow goes down. Is that Vyzulta, one mechanism that the company talks about is a Vyzulta may have the benefit of increasing nitric oxide production, which causes vessels to dilate and can improve blood flow to the optic nerve. Because again, an interesting concept. So we have this whole class of medications that we can use to directly treat the trabecular meshwork where the problem actually exists.
In clinical practice, do you find it to be a big advantage to use Vyzulta because of the increase in nitric oxide and being able to be a vasodilator, or do you find it pretty similar to the other prostaglandins?
I haven't found any. I can't. So for example, if we do an ODM test, Carrie, we see no difference. So if we measure the actual blood flow, we see no difference with Vyzulta versus one of the other prostaglandins.
Thanks for that. Now I want to ask you about Durysta, putting that little implant in the eye. Have you used that, and do you have an opinion on that?
I haven't used that medication. I haven't used that implant in the eye, and the reason, well, there are several reasons why I'm being very frank about it. Number one, topical prostaglandins. I think the benefit of Durysta is if you have an issue of noncompliance. That is, a person's not going to use their medication, their drops. I don't find that to be an issue. So when we talk about compliances, the more complicated a regimen is that you give to a patient, the greater the likelihood that they're not going to comply because life gets very distracting. So people don't usually have much of an issue putting a single drop in their eye at night, which is all you have to do with a prostaglandin. And the other issue with Durysta is there's a payment issue. So there's an issue with insurance companies covering it because they say other therapies are just as effective and available. So in general, my own personal regimen, Carrie, is that I will go to a prostaglandin. If there's an issue with compliance or an issue with payment, I will then move on to a laser trabeculoplasty to treat the trabecular meshwork, or I will use a prostaglandin in combination with the laser to open up the drain of the eye, right? And then if it doesn't work beyond that, they're still progressing, we might have a conversation about Durysta, but I have found that a lot of patients don't like the concept of putting a drug directly in their eye.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
Now let's talk about beta blockers, an old favorite of ours, Timoptic, the yellow cap, decreasing production of fluid. Tell me about that, how effective it is. And also, just to backtrack a second, the prostaglandins, any significant side effects that we have to know about? And then with the beta blockers, any significant side effects?
So with the prostaglandins early on, Lumigan gets into the chemical. Lumigan, the way their original molecule was structured, that the original molecule had some vasodilation properties. So people using it would notice their eyes would get red after prolonged use. The company reformulated the Lumigan and that problem has gone away. So you see very little complaints. And the other interesting thing, I'm glad you asked that question, Carrie, is that there's something that we call, it's a term that doesn't make sense. We call it tachyphylaxis. Tachyphylaxis means that an eye will develop a resistance to a drug over a prolonged period of time. The drug will become less effective. Interestingly enough, we don't see that a lot with prostaglandins. I've had patients on prostaglandins for 10 or 15 years, the same drug, and it's as effective as it was from day one. So we don't see a lot of resistance to prostaglandins developing within the eye. And systemically, there's no significant side effect. The only thing I would mention that I am careful in prescribing prostaglandins to a patient who is trying to conceive. because so if you go to the hospital and they want to induce your uterine muscle to contract to induce your labor to get you moving along, they will infuse a prostaglandin. Pitocin is a prostaglandin. The medication is given to females to induce pregnancy to move it along. And I once had a patient, one of the greatest benefits we can do, and something you would never get your hands around, I believe, going back to telemedicine again, Carrie, I'm trying not to beat a dead horse, but when you meet a patient, face-to-face contact is very important to find out, what the issues are here. And we do have a lot of interesting issues. So I saw a patient once in consultation that was she was trying to conceive a child but had multiple pregnancies, and she was being treated with a prostaglandin. And I said, well, there's a potential that the prostaglandin drop you're using could be the problem. We stopped the prostaglandin, and she carried a full-term pregnancy.
Holy cow, that's amazing. I never heard that before. Thank you for sharing that.
So Pitocin, when you go to a hospital to induce the pregnancy, is a prostaglandin that causes contraction of the uterine muscle.
Wow. You just
So
a lot of doctors on that.
Yes. So, yep. So I would be very careful about that. But other than that, the side effects, very safe profile and very little allergic reactions. Beta blockers, very effective medications. But the issue with beta blockers are they decrease the aqueous humor production. They decrease that clear fluid production. Very, very effective medications. We use them for a long time, but there is a potential for side effects. There are drugs that you cannot use in people with pulmonary diseases like chronic obstructive pulmonary disease, bronchospasm, asthma. There are drugs that you would have to avoid in those circumstances because they have a potential side effect of causing narrowing of the airways. They're also, and this is from a drop applied in the eye, they also can slow down the heart rate, something we call bradycardia. So you have to be very careful about that. I have had an eye-opening experience for me when I was going through my training. We saw a patient in the clinic with ocular hypertension, talked about treatment. Again, given my gray hair, I've been practicing for a long time. We didn't have prostaglandins. Put the individual on in the clinic. We would always institute therapy in the clinic, watching potential side effects. This individual was in the intensive care unit within 6 hours. Went into complete total bradycardia. Pulse rate went from 72 down to 20.
Wow.
From one drop of a beta blocker in the eye. So they're very effective medications, but you have to watch for potential side effects, slowing down the heart rate, constriction of the airways. There's some suggestion that in men, they can lethargy, make people feel fatigue, decrease sexual drive in men. There's some studies suggesting that. So the beta blockers as a class have a greater risk profile when compared to the prostaglandins.
Let's move to the alpha agonists, our old buddy alpha-GAN, bromonidine. Talk about that, decreased production, increased outflow.
Yeah, alpha-GAN, right, dual mechanism of action, decreases both aqueous humor production, positive effect on outflow. Very good medication in my mind as an add-on to a prostaglandin. So again, if I have a patient that's on a prostaglandin, they're not their target, I'm not on target where I want to be, I'll add alpha-GAN on board, or I might do a laser trabeculoplasty. It used to be with the original formulations of the alpha-GAN, about 40% of patients after extended use would develop a severe allergy to the medication. That problem has gone away with the newer formulations, but a very, very effective medication. The only potential side effect I've ever seen of alpha-GAN is some patients will complain of a dry mouth. You'll hear them talk about that, dry eye, dry mouth. So
now with alpha-GAN or bromonidine, with the generic versus the branded product, is it generic? Can they still blow up on people where they get that bad red eye?
Yes.
To the brand. So it's really been corrected in the brand and not so much in the generic. Is that correct?
That is correct, Gary. Yes. Yeah. It's the reformulation, and the branded is much better tolerated.
Let's go to carbonic anhydrase inhibitors, decrease production of the intraocular fluid. Tell me about your opinion on those. The old Trusopt, Dorazolamide, and Azopt that we see. Tell me about that.
Well, when I was a fellow, we did the original studies on Trusopt, and we did not find it to be that effective a medication in terms of lowering intraocular pressure. But the issue was, it's an add-on. It's like a third-tier medication that someone might add on. So, typically the go-to should be a prostaglandin, and then maybe Alphagan or maybe a beta blocker if you feel comfortable giving that to a patient. Trusopt is a third-tier add-on. And so when you're adding a drug on as a third tier, you're always going to get less effect from it because you've already maximized the treatment with two other drugs. So when you add a third tier on top of it, you're going to get a little less bang for your buck, I would say. So I don't prescribe Trusopt that often. The other thing, it is a sulfa medication, Azopt, Trusopt, sulfa medication, very high tendency for allergies. Patients find it to be very irritating for the eye. And in reference to that, I think if you want to enhance that a patient's actually going to comply, patients in general want us to do, they want to do what we like them to do as a provider to support their eye health. But if you prescribe a medication, which when placed in their eye burns or is uncomfortable or causes their eye to be red, that's a very difficult circumstance in which you could expect them to comply with the medication. I mean, none of us likes to do anything to ourselves that just doesn't feel comfortable. So for that reason, in my armamentarium, I would say that Trusopt is not something I prescribe on a regular basis. Gary?
Speaking of red eyes, that brings us to the last category, the new kid on the block, the rho kinase inhibitors. They could work well, but the eyes could blow up and be red in a much higher percentage than in my opinion, than the company says it does.
I agree. And again, when you do that, you can expect, in reference to the compliance issue, I always want my patients to tell me what they're actually doing. If you're not using the drops, tell me. Let's have a conversation. Why? Is it a financial reason? Is it because they bother your eye or you just don't remember? Let's have a discussion about it. And if they say, well, doc, every time I put this drop in my eye, it turns beefy red, and people are wondering, am I drinking too much or what am I doing? So I always, try to, make the prescription something the patient finds easy to comply with. So.
And I have to ask you about marijuana, because if I don't, I'm going to get 100 or 1,000 emails. Why didn't you ask the doctor about marijuana? So patients, I'm sure, ask you about it because they asked me about it. So what do you think?
Well, if you look at the studies, marijuana, after someone smokes a joint, it lowers the intraocular pressure by 2 millimeters of mercury on average. Nobody has really looked at what it does to outflow. If I think that marijuana was an effective medication as a treatment for glaucoma, Gary, I think a pharmaceutical company would have studied what the component was, developed it as a drug, gone to the FDA, and had it approved as an eye drop. That's my opinion on it. Does marijuana have a role in medicine? Yeah, it does. We know that. End of life, people with severe pain. There's a whole host of issues for it. But I think the data as a treatment for glaucoma is fairly weak.
Let's talk about some of the surgical options. And you mentioned before SLT, selective laser trabecular
plasty, yes.
Trabeculoplasty, thank you. So what do you think about SLT as a first-line treatment?
Again, compliance issues, right? When I'm going to initiate a form of therapy with a patient, say a newly diagnosed glaucoma patient, I will have a conversation about, here are options. We can put you on a prostaglandin drop, which you can use 1 drop at night in each eye, right? Or the other option is to do an SLT. The study that was done, medication first versus laser first, they both were equivocal. The question is, what is a person willing to comply with? What are they really willing to do? And then, of course, the other thing we talked about with the prostaglandins, there is a potential issue with prostaglandins. They will make the eyelashes grow longer after prolonged use. And there's a possibility in a green-brown iris, they'll cause darkening of the iris. So I think if you see one of those patients, you have to have that conversation saying there is a potential risk your eyelashes could get longer. More of an issue if you're going to do a monocular treatment in a male patient, for example, or even a female patient, or if the iris is green-brown, a conversation about prolonged use, it could darken your iris. And then also, in some patients, though I don't commonly see it, there's an issue with raccoon eyes where you get increased pigmentation surrounding the eyes. So I will have that conversation and lay that out and give them the option. We can do the SLT. It works the same as a prostaglandin. You don't have to use a drop, or we can do the drop. Which one are you more comfortable with? And we'll proceed from there, because the goal is to have them comply with the treatment so that we can prevent blindness. So what's going to work best for them?
And how long does the SLT work? If you do it, will it last? How many years will it last? Will it continue to lower the pressure?
General concept, 50% of individuals will require an additional SLT within 5 years.
You know, one of the things I've noticed, you know, from doctors near me who treat glaucoma, who surgically treat glaucoma, will refer for SLT. They'll take all the patients off all their drops, do the SLT, and then the patient comes back and the pressure's back up to 30. They always take the patient off the drops, and then the pressure goes way back up again. I'm not sure why they do that unless they have so much confidence in SLT. I haven't seen it work so good where the patient should stop all the drops. Now, of course, people listening to this, you got to do what your doctor says. We're just having an educational discussion. But from your point of view, I never understood that.
I don't stop the medication. As I said, so if I have a target outflow value or a target IOP value, consequently, where I want to lower somebody, and if I put them on a prostaglandin and I'm not there where I want to be, then I will not stop the prostaglandin. I'll do an SLT in addition to that, but I'll use the two things together because they're both treating the outflow system. So versus you always, in my mind, you always get a bigger, greater bang for your buck when treating the outflow system, because versus if someone's on a prostaglandin, then would I put them on a beta blocker? Not necessarily, because of the systemic side effects. If they didn't want to do a laser, I'd add Alphagan. But an SLT is an add-on to therapy. It's a stepwise approach outside of that patient. So in general, my belief is it's a stepwise approach. Patient wants to use medication, start off with medication. Medication doesn't have you where you need to be. Don't stop the medication, add an SLT on board. Or from the get-go, if a patient doesn't want to use the medication, do the SLT. And if the SLT doesn't get you where you need to be, then add a prostaglandin back on board. So you're always treating that outflow system. But I don't stop the medication because that prostaglandins we know are effective. We don't see tachyphylaxis where the prostaglandin medication loses its effect over time. We don't see that very often with prostaglandins. So in my mind, I don't know why you would stop a prostaglandin medication when doing SLT.
How about, let's go to MIGS, micro-invasive glaucoma surgery, or as other people say, minimally effective glaucoma surgery. So do MIGS work, and how well do they work? And what are they? First, tell us what they are, and then tell me how they work.
Right. So a MIGS, again, the issue is the drain of the eye. So fundamentally, glaucoma is a plumbing problem. We have a faucet, we have a drain. The issue is not with the faucet, the issue is with the drain. So we want to direct all our therapy at the drain. So now we have these procedures. We have procedures which, quote unquote, are designed to surgically make the trabecular meshwork work better. So I will say the following based upon my own experience. So the resistance, the greatest resistance in the outflow, where the problem really is in the outflow system of the eye, is the outer wall of a structure called Schlemm's canal. That's where the resistance is greatest in the trabecular meshwork. All the studies have demonstrated that. So in my mind, I don't understand anatomically. So some of these mixed procedures only treat the inner part of the drainage system of the eye. There's one that treats the entire, bypasses the entire system, but ones that only treat the inner system of the eye, I don't anatomically understand how they can work. I've used those devices. I haven't had good success with them. The device that I have a go-to for is a procedure called a Zen procedure. And the Zen is a microscopic tubule that bypasses the entire trabecular meshwork. So what it is, it's a microscopic pipe that's implanted in the trabecular meshwork. So it goes from inside the eye and drains the fluid into a reservoir in the subconjunctival space. So you're bypassing the entire system. Because again, studies have shown, it's documented well in the literature, that the problem in the trabecular meshwork where the dysfunction is greatest is in the outer wall of Schlemm's canal. The other devices that are the MIGS devices do not get anywhere near the outer wall of Schlemm's canal. So how is it that they're working? The other thing I have seen is the other two devices are made out of stainless steel and they have a tendency to migrate when inside the eye. So they have a tendency to move over time. So my experience, the other two devices are not as effective as the Zen device.
And who makes the Zen?
It's made by a company called Allergan, or AbbVie is the primary company. And it's a microscopic tubule that bypasses the entire trabecular meshwork. So it's like putting a new drainage system in the eye that's going to drain into the space underneath the tissue on the surface of your eye.
And how many points do you usually see that it lowers the pressure?
In the initial, from day one, like post-op day one, you'll see the pressure drop and the outflow increase over 50%. And then what happens over time, as the healing takes place, about 4 to 5 weeks out, you'll see like a 30% improvement. So go from a 50% improvement to 30% improvement as the healing completes itself, Gary.
And how about trabectone, removing portion of the trabecular meshwork? Is that something that you think has a place and you think it works very well?
Most of the studies of my colleagues, I've never used a trabeculotome, say that scars down over time. So you get scar tissue formation, it forms and the hole plugs up again. So I don't believe that's a device that's commonly used anymore. Not aware of any of my colleagues. Right?
And the last part, before we get into my favorite part, where we're going to talk about the device that you developed, tell me about trabeculectomies, about filters, and how complicated is that surgery? And, I had a patient the other day that was very worried that the bleb was going to grow in front of her pupil. Tell us about that.
So a trabeculectomy is, so the most common procedure done is called the mitomycin trabeculectomy. And I actually was one of the individuals when I was a fellow at University of Michigan. That procedure was developed by myself, Dr. Gregory Skuda, Dr. Paul Lichter, Dr. Eve Higginbotham. So a trabeculectomy is literally where you remove a portion of the trabecular meshwork. It's usually about a 1 by 2 millimeter portion. You take that out, and then you take the white part of your eye is called the sclera. And so you create a scleral flap. And the purpose of that flap is to offer resistance to outflow because you don't want the eye to be too soft, right? You want an improvement in outflow of aqueous humor. And again, you're doing this procedure because the trabecular meshwork has failed. The patient has failed medical therapy. They have failed they have failed laser therapy. The therapy has not worked and their glaucoma is getting worse. So a mitomycin C trabeculectomy is a very aggressive procedure, but it still has its place. And again, you're actually removing a 1 by 2 millimeter portion of the trabecular meshwork. You're creating this little flap on the surface of the eye so that the aqueous humor, the clear fluid, flows out from underneath the flap, but it offers some resistance to outflow. Because if you made a 1 by 2 millimeter hole through the trabecular meshwork and there wasn't anything covering it, the eye would collapse. The issues with the mitomycin C trabeculectomy is the postoperative management. The eye is very soft for the first several weeks. The patient's on restrictions. You have to cut sutures that are in the flap that acts like the flap valve using a laser. So there's a lot of postoperative care that's required. There's a lot of visits to the doctor's office, but it has a place in advanced glaucoma. But it's a much more difficult procedure for a patient to go through because of the restrictions and the postoperative care required, Gary.
And I've seen filters where they were flat and there was no, it wasn't elevated and it was still working.
Yes.
Why does that happen?
Aqueous humor production went down. So for whatever reason, the aqueous humor production was decreased. And that could be, that's what happens a lot. If you have inflammation within an eye, the eye becomes inflamed as a result of a surgical procedure. The production of aqueous humor, the clear fluid of the eye, goes down. So if you were to see an eye that had a trabeculectomy and they have a flat bleb, there's no aqueous humor there, and the eye pressure is low, you want to get very aggressive with managing the inflammation to try and get some aqueous humor production back.
Your eyes and your vision are under attack, damaging blue light from the sun. Your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.
OIE Broadcasting is the emerging leader in social media. We use scientific entertainment to drive more patients into your office. Visit oiebroadcasting.com and sign up today.